happening. It is my pleasure to bring you the 2025 ESMO Nasopharyngeal Carcinoma Progress Highlights from Berlin, Germany. My name is Jonathan Cheng, and it is my pleasure to host today's event. I am the Chief Medical Officer of SystImmune, and I'd like to introduce our distinguished panel today. First off, we do have Dr. Jun Ma, who is the Yat-sen University academician of the Chinese Academy of Science.
Ladies and gentlemen, distinguished colleagues, good evening. Welcome to the 2025 ESMO NPC Progress Highlights. I'm Dr. Jun Ma from Sun Yat-sen University Cancer Center, and it's my great pleasure to serve as the chair of today's meeting and join you all in discussing the future of nasopharyngeal carcinoma. In recent years, significant progress has been made in the systemic treatment of nasopharyngeal carcinoma. Particularly, the combination of immunotherapy with the GP region has become the standard first-line treatment for recurrence or metastatic NPC. However, once patients experience disease progression on this region, subsequent treatment options are often limited due to durable resistance to both platinum and immunotherapy. This setting has long lacked high-level evidence from clinical trials and can be regarded as a desert of evidence for post-line therapy. At present, the response rate of conventional chemotherapy at this stage remains around about 30%, which is far from satisfactory in meeting clinical needs. Again, this backdrop, the BL-B01D1303 study we are focusing on today is of particularly importance. It's not only the first phase 3 randomized controlled trial for post-line treatment of NPC, potentially filling this evidence void, but also the first global phase 3 clinical trials of bispecific ADC, making the transition of this innovative therapy from proof of concept to comprehensive clinical validation. I believe that today's in-depth discussions and the insights surrounding this milestone study will inspire new perspectives and reflections. I wish this meeting a great success and hope everyone will enjoy an engaging and fruitful exchanges. Thank you.
We also have to my left Dr. Zhou, who is a medical oncologist and associate professor at Sun Yat-sen University Cancer Center. And then to my right is Dr. Melvin Chua, who is a radiation oncologist, physician scientist at the National Cancer Center of Singapore. And then to my far right, Dr. Petr Szturz, who is a medical oncologist, attending physician at Lausanne University Hospital. And it is a great pleasure for us to have a very important and lively discussion on the data that was presented today at ESMO on nasopharyngeal carcinoma. We will first have the presentation of the first randomized head-to-head comparison of Iza-Bren versus chemotherapy that was at the oral session today. And then we will have a panel discussion about the implications and significance of those results to the wider cancer community. And with that, I will ask Dr. Zhou to give the keynote presentation from today.
Okay, thanks for the introduction. And it's my great pleasure to share our study again in this time. Okay, today I will share our phase 3 study This study compared Iza-Bren and compared to chemotherapy in heavily pretreated recurrent or metastatic nasopharyngeal carcinoma. Here is my declaration of interest. As you can see, nasopharyngeal carcinoma has a very high incidence among Southeast Asians, and the survival of an early and local advanced disease has been significantly improved. However, about 20 to 30% of patients have recurrent or distant metastasis. The first-line therapy for these patients is immunochemotherapy, but when patients progress after the first-line therapy, the treatment options are limited. So here highlights a major unmet medical needs for these patients. Our study drug, Iza-Bren, is a first-in-class ADC comprised of EGFR and HER3 bispecific antibody conjugated to a top 1 inhibitor payload with a drug-to-antibody ratio of 8. In our prior phase 1 study, we had saw Iza-Bren and has a promising activity among nasopharyngeal carcinoma patients. And the objective response rate was about 59%. So this encouraging result led us to conduct this phase 3 study. And here we report the first interim analysis. This slide shows our study design. It was a multicenter randomized open-label phase 3 studies conducted at 55 centers across China. We enrolled heavily pretreated patients who had received PD-1 inhibitors and at least 2 lines of chemotherapy. Patients were randomized 1-to-1 to receive either Iza-Bren or chemotherapy until disease progression or intolerable toxicities. This study used dual primary endpoints, the objective response rate by BCRS and overall survival. The secondary endpoints including progression-free survival, objective response rates assessed by investigator, duration of response, disease control rate, and safety. At the data cut-off date of March 30, 2025, 522 patients screened, 386 patients randomized, 191 patients assigned to the Iza-Bren arms, and 195 in the chemo arms. 97 patients still remain on treatment in the Iza-Bren arms, and compared to 46 patients in the chemo arms. The most common reasons for end of treatment is progressive disease, patient withdrawal, and treatment delayed. We can see the baseline characteristics between the two groups were well balanced. The median age was 50 years, and the over 80% of patients were male. Majority of patients has an equal PS of 1, and we can see our patients was heavily pretreated. Over 40% of patients has received 3 or more of prior treatments, and nearly half of patients have the liver metastasis. The interim analysis is triggered by the first 234 randomized patients with at least 6 months of follow-up. This is also our final analysis of objective response rate. The median follow-up was 7.66 months for Iza-Bren arms and 7.1 months for chemotherapy arms. And we can see that Iza-Bren has a much higher objective response rate compared to chemotherapy, from 27% to 54.6%. the p-value was less than 0.001, and Iza-Bren has a 8.5 months duration of response, which is higher than chemotherapy 4.6 months. Moving to the subgroup analysis, we can see all subgroups has the same OR benefit from Iza-Bren. For the progression-free survival, we can see Iza-Bren nearly double the median progression-free survival from 4.34 months to 8.38 months. The hazard ratio was 0.44. And this clinically meaningful PFS benefits was seen across the different subgroups. Let's look at the safety. The rate of grade 3 or higher treatment-related was 79.9% in the Iza-Bren arms, which is higher than chemotherapy arms. And 41.8% of patients in the Iza-Bren arms have the treatment-related adverse events leading to dose reduction, and 61.4% to dose interruptions. But these events was well managed, and we can see the rate of treatment discontinuation due to the treatment-related adverse events was lower, with only 2.6%. Treatment-related adverse events in frequency more than 20% was shown in this slide. We can see the most frequent grade 3 or higher treatment-related in the Iza-Bren arm were mainly hematological, and they are well managed by the standard supportive cares. The majority of the non-hematological treatment-related adverse events was grade 1 or 2, and two patients experienced grade 2 ILD in the Iza-Bren arm versus 2 grade 3 in the chemotherapy arms. No new safety signals were identified. So in conclusions, this was the first randomized phase 3 study evaluating ADC in recurrent or metastatic non-small cell nasopharyngeal carcinoma. And we can see our study has reached its primary endpoints for objective response rate. It also showed a clinically meaningful improvement in progression-free survival, and the safety profile is manageable without new safety signals. So based on these results, we hold the belief that Iza-Bren represents a potential new standard of care for heavily pretreated patients with recurrent or metastatic nasopharyngeal carcinoma. And our work also published in Lancet at the same time. Finally, I would like to thank all the patients and their families for their participations, and all investigators and research staff in this study. Thank you for your time. That's all.
So I want to thank you for an encore presentation of a very important randomized registration enabling trial comparing for the first time for a bispecific ADC head-to-head of an ADC with a topo-1 payload compared to standard chemotherapy. So thank you again for showing us a very exciting and interesting data. As you know, we have a very large audience that is evaluating and wants to learn from it. So what would you consider to be like the take-home messages of this presentation as you would summarize?
Okay, as we know, this is the first randomized phase 3 study evaluating ADC in nasopharyngeal carcinomas. So we can see our efficacy data was very impressive, and we can see it as of the data cut of this interim analysis. We can see it, the median progression-free survival was higher in Iza-Bren arms from 4.34 months to 8.38 months, and the primary endpoint objective response rate was nearly doubled from 27% to 54.6%. So I think this increased efficacy data is very important, and we can focus on the safety. It was manageable, and although our adverse events was mainly hematologically, but they can be managed with the standard supportive care, and the rate of the treatment discontinuations was low. So I think it will be a new therapies for recurrent metastatic nasopharyngeal carcinoma in the future.
Great.
That's
No,
all.
thank
Okay.
you, Dr. Zhou. So if I may turn to our panelists. So Melvin, you have helped define the standard of care and written a lot and published a lot in nasopharyngeal carcinoma. It's always great when there's a positive phase 3 trial. How do you view this data, and what is your perspective on the data?
So, must first declare some conflict that I was actually one of the reviewers of the paper.
Even better.
And
Insight.
it was extremely impressive. I mean, I won't repeat what, Dr. Zhou has very elegantly showed. I think the data speaks for itself. Clearly this is a game changer. It's hard to beat chemotherapy for this disease. And while I think one of the things to put it to the audience is that, while these were heavily pre-treated patients, for most of us who treat NPCs, we know that, these cancers are still very sensitive to chemotherapy. So, to have a drug to be able to beat it so, compelling in such a compelling manner, it's impressive. Now, let's look a bit deeper, right? I think given that the trial was mostly done in China, a question I had was, what's the proportion of patients that saw immunotherapy? Now, the access to immunotherapy, specifically anti-PD-1 antibody, may not be so pervasive outside of China. So I imagine that for most of these patients, they will have seen some form of immunotherapy. So then this will speak to the fact that perhaps something about Iza-Bren does, circumvent resistance to anti-PD-1, which then, makes us think a bit deeper. What are the mechanisms of action, right? What is actually working here? And then we know that the immune environment is extremely important in nasopharynx cancer. So, what aspects of the tumor microenvironment is being exploited to see such big effect sizes? I think that's one question I had in terms of perspective.
Yeah, so it's a great question, and it's an important one. I do think, given the relatively large portfolio data, in general, I think ADCs have shown to be relatively active with or without prior immunotherapy. I think the previous presentation for Iza-Bren across many cancers probably suggests that, but it's an important question because IO can change the microenvironment and subsequent therapy, so it's an important thing to continue to understand. I'd also like to turn to Petr, if you don't mind. Obviously, recurrent metastatic, heavily pretreated, they're kind of sick patients in a tough situation. I would be interested in your view as a head and neck specialist, like how do you view this data and its potential significance?
Well, these data have extreme significance, I would say, from two perspectives. I mean, the first is a perspective for, in general, development of drug and drug development. To have a positive trial nowadays is not something expectable at all times. I mean, the majority of phase 3 trials are still negative. So to have a positive trial is always something welcome, and to have a trial which is positive, which with such a difference, I mean, with a doubling of survival, progression-free survival almost, and also almost doubling a response rate, this is something unheard of in nasopharyngeal carcinoma, and it's quite rare also in other diseases. And I think it's also important to think about how the development of clinical research will continue. And the traditional view is that phase 1 trials are for patients who do not have any other treatment options, while phase 3 trials are in the first line. typically, but this changes. And we see, for example, first-line trials in phase 1 setting. So this may be, I would say, a little bit difficult field also to propose a phase 1 study in the first line. But I think that drugs like the Iza-Bren really give us the rationale and justify to use it as early as possible. Of course, I'm very much aware of the fact that this was a phase 3 late-line clinical trial, but I'm just trying to share my perspectives, how this may change also the field of how clinical trials are developed and followed in the future. I think that another significance I see is for the ADCs in general, because we know that these drugs are already approved in several solid tumors, also hematological malignancies. And as Mel mentioned, they are indeed game changers for not only for nasopharyngeal carcinoma, but also for other diseases. And speaking more specifically about head and neck cancer, so in Europe, where I'm practicing, the most common type is squamous cell carcinoma of the head and neck. And even in this disease, there is already a promising ADC enfortumab vedotin, which has also shown efficacy as a monotherapy in heavily pretreated patients. And now with the advent of Iza-Bren, I think the landscape will change very soon in nasopharyngeal carcinoma. It is also of note that the Iza-Bren is not the only ADC that is tested in nasopharyngeal carcinoma. We have seen already some data with the Bicottatug, which was a smaller study, but still the data were positive. And there is another ADC, which is the B7H3 targeting ADC, which is under development in an ongoing clinical trial. So this field is rapidly evolving, and I am personally looking forward to seeing more data on this.
Sure. I think those are great points. I think I want to delve deeper into this concept of this impact on clinical trials. So obviously the gold standard is phase 3 head-to-head comparison of, in this case, an ADC versus chemotherapy. But there are many trials, phase 1, phase 2, phase 3 to build to it. So I'm interested, maybe Dr. Zhou, first your perspective, like knowing that an ADC can be superior to chemotherapy, how do you think that impacts your views and your concepts of how we should be conducting phase 1 and phase 2 and phase 3 trials, particularly as ADCs, as Petr mentioned, is moving into this arena?
Yes, okay. This our study just compare Iza-Bren to the chemotherapy in nasopharyngeal carcinoma. I think it holds clinical significance on the ongoing phase 1, phase 2, or phase 3 trials across multi-cancer types. And especially in the China, we have many patients. But I think it provides important clinical evidence on the safety profile of Iza-Bren.
Sure.
Because you see it, and the Iza-Bren, its toxicity is mainly hematological. So from our study data, we can see that we can manage it better. So this experience, I think it can extend to other cancer type and other drug trials.
Sure.
So I think in addition to the treatments of nasopharyngeal carcinoma, our study also had the clinical significance in evaluating ADC in these cancer types.
Sure.
Okay.
No, very good points. And then Pete, maybe similar, like how do you think about trials knowing that ADCs are entering this field? And then how would you design either or think about current or maybe future trials as to where you'd be most interested in either phase 1 or phase 2 or phase 3 setting?
I mean, the critical point will be sequencing and combination.
Sure.
So this is something that needs to be tackled very early on to make a good strategy how to pursue with a drug. As far as combinations are concerned, so clearly combination with immunotherapy is something that we have to think about in the first place.
Sure.
But we may be, I would say, a little bit cautious because we've seen some data in the past showing that the combination may increase toxicity. For example, as far as the interstitial lung disease is concerned. And so I was quite reassured when I saw the results of the current study that the ILD incidence was not increased significantly. So this is an important point also for doing perspectives as far as different combinations are concerned. Again, chemotherapy in doublets or triplets is another choice. And regarding the sequencing, so I would say a very natural way how to proceed is to try to give Iza-Bren earlier, even in the first-line setting. But of course, we will need clinical data in order to justify this. So this is the road ahead of us, but I think it will be an exciting journey also for the patients enrolled in these trials.
Clearly, desiring better patient outcomes, very exciting, much work ahead of us. I do want to delve a little bit deeper into nasopharyngeal carcinoma itself. So as you all know, the first-line recurrent metastatic nasopharyngeal carcinoma is often platinum doublets plus checkpoint inhibitor. But later lines, chemotherapy is used, but maybe of limited or durability and significance. I'd be interested, based on what you saw on the study, how you think the landscape of nasopharyngeal treatment might be changing in China, either soon or in the near future.
Okay, from the China inspect, I think recurrent or metastatic nasopharyngeal carcinoma and still have a unmet medical needs. Although the first line therapy was standard immunochemotherapy, but when they failed, we have limited treatment options, and we can see the objective response rate of the chemotherapy was about 20 to 40% of. But we also should notice that this clinical efficacy data was come from the small or single-armed study. So we still need the most large clinical study. So Iza-Bren, I think it can fill this gap. In China. And actually, we have submitted a new drug application for conditional approval in China in September this year. So we hold believe that we will make it to accessible to more patients in China in the future.
Sure. Okay. Very important to provide access. Similarly, Melvin, if I ask you a similar question, how do you view the landscape changing? Because that's actually a good thing, because that means we're helping patients and do better. But, particularly in this very tough situation, recurrent metastatic.
Yeah, so I think I'll give two perspectives. I'll start with the recurrent metastatic. So actually, together with Professor Junma, we are co-chairs on this Cisco-ESCO guidelines for when we're looking at the guidelines for recurrent metastatic advanced NPC. And I think you really got to dissect the landscape in two ways. I think as Dr. Zhou nicely sort of highlighted in China, right now, there's pervasive use of anti-PD-1 antibody in combination with chemotherapy as first-line treatment. I think the rest of the world hasn't quite caught up yet. So I think the value of the study, it's very intuitive in China, but I think for the rest of the world, given that most times we still start with doublet chemotherapy, and as we increasingly use more anti-PD-1, I think we're going to see IO refractory disease, and then so this becomes an option. And I think it's important because at least it gives clinicians some confidence that we don't have just one therapeutic agent, that because in the past after chemotherapy then we think about IO and then re-challenging with chemotherapy. So we go around in cycles. I think now this gives us a reassurance that we have options out there.
Sure.
Now then, if you then look at the locally advanced space, I think that's where the big segment of patients are actually from.
Sure.
I think a couple of things comes to mind. I think one is, the tolerability of this drug. There's some toxicities, but not like your typical ADC. So we see a lot more hematological toxicity. So I think for us, when we think about the application of this drug beyond recurrent metastatic setting, at least we know now we have a effective combination, as Petr nicely highlighted earlier. We now have a drug that potentially may combine well with immunotherapy, may be may have efficacy in the locally advanced space. So then the toxicity becomes important. So when chemotherapy remains a backbone with radiation in the treatment of locally advanced disease, we then have to think about, if you add this drug on top of that, how do you sequence? Will it compound on the hematological toxicity? Will it affect tolerability? I think that's some important things that comes to mind at this juncture. Then of course, this calls for patient selection. How are we going to choose patients? Are they biomarkers to decide who gets this drug? Hit them early, hit them hard,
Sure.
And then that basically improves survival. So I see this space evolving, and it's quite exciting with this new drug.
Yeah, no, thank you for that. I maybe delve into a little bit of the toxicity. So we did see the toxicity panel and the preferred terms and the adverse events, which seem to be lab-based and hematologic. I'd be interested in your perspective, Dr. Zhou. Like, how do you view the side effect profile of Iza-Bren, and how do you manage these side effects?
Okay, this is an important question. As we can see it, actually, Iza-Bren arms has experienced more grade 3 or higher treatment-related adverse events, mainly the hematological events. I think it mainly comes from the payload, EGFR, the top one inhibitors.
Sure.
But we have many standard supportive care to treat these situations. And we can see actually in our Lancet paper, we also said that the median recovery time from the neutropenia or thrombocytopenia was about 4 to 5 days. So this time, I think it will be successful in our clinical management. And so you can see the dose reduction and the dose interaction rate was higher in this group, but the treatment discontinuation rate was low, about 2.6%. In addition, Iza-Bren the incidence ILD in Iza-Bren is known. Is lower than chemotherapy arms in our study. So I think this is another different point from other ADCs.
Sure. Thank you. No, really, really helpful. So so first, thank you, panel member, for a really important and interesting discussion. I'm going to close with the last question about looking to the future. How do you view, we mentioned a couple things, we mentioned local advanced, we mentioned combinations, but how do you view, like, what's top of mind for you regarding the current and future opportunities of Iza-Bren or ADCs in the development of cancer? Like, how do you think about it? What's most passionate, or think the highest thing on your mind? Maybe I'll start with Petr, if you don't mind, just what's on top of mind regarding the future development?
Yeah, I mean, regarding the future development, I'm still thinking about the OS data, which haven't been presented, which indeed might be quite important also for regulatory aspects. But on the other hand, with this difference in response rate and this difference in progression-free survival, it would be hard to imagine that the OS data wouldn't be positive.
Sure.
But this is indeed something on my mind that I would like to see to be reassured, but I'm quite positive about it. And of course, the next step is to clearly define which patients should should receive it, if we can already start treating, for example, in the second line based on the results of this study. And the next step would be to move it to the first line. And then the principal question would be whether we will rely on a single agent activity. And this is something very important, because what is quite impressive is that all these results have been achieved with a single agent drug.
Sure.
And you know that, for example, the standard of care, as Mel so nicely reviewed, is a chemoimmunotherapy. So basically you give 3 drugs. And now you have already one drug in heavily pretreated patients that leads to such wonderful results. So I'm wondering what would be the take on it in the first line, whether there will be still space, for example, for single agent treatment. We have to consider that if we add immunotherapy, if we add chemotherapy to Iza-Bren, the toxicity will increase in any case. So this will also be, let's say, a decision to be done, whether there will be, for example, some patients for whom monotherapy would be more appropriate than combination treatment. So I'm very positive about the results and looking forward to hearing more about it.
Yeah, likewise. So maybe we invite Dr. Zhou back when the OS results are mature for this study, right, to be able to show it at a future Congress or presentation. But same question to you, Melvin, like what's top of mind, what are you most excited about as far as future opportunities?
Well, I think I will look forward to the OS data just to harp on that point again, and then you can have us back again. But
we'll have you back.
The manifolds, I think, while it's very exciting, it goes back to this point I made earlier about mechanisms of action, biomarkers. I think ADCs has really sort of opened a whole new therapeutic window of opportunities. But at the same time, we need to really understand why does it work so well in heavily pretreated nasopharynx cancer as well as other cancers. And we should not have this very sort of simplistic notion that the same drug that works in NPC and in bladder cancers works the same way across all cancer types and across all scenarios. So I think that's one. And then it will allow us to then think about drug development in a more profound fashion as we think about how do we design sensible trials in locally advanced disease, right? Pembrolizumab was a perfect example for that. It worked perfectly in recurrent metastatic head and neck squamous cell carcinoma, but then the excitement was very quickly tapered with all the locally advanced trials. So that's how I would like to see the field evolve. I'll be very excited to see these drugs being pushed into the earlier line setting. And as I always say to my trainees, I think this is where you cure patients. You don't cure patients in the second or third line setting. But then when we want to do something like that, we have to be very clear about what are toxicities, how do we select patients, and how we design good trials. I think that's very important.
Sure.
So just want to make that point.
Yeah, completely. Our ultimate goal is curing patients so they can live long and healthy lives. And so, Dr. Zhou, back to you in full circle. What are you most excited for as far as future opportunities of Iza-Bren?
Yes. And I'm agree with these two professors. And I just add another point. Actually, we also express the Iza-Bren combination with immunotherapy in the first line setting in the nasopharyngeal carcinoma or other solid cancer types. And actually, we also try to do some biomarker analysis in this field, but there it's too early to set this result.
Sure.
Yes. So I think that Iza-Bren it will be brought me more and more data in the future, including you said the overall survival. But that is no matter now. I think it will be in the later of the 2026 or 2027. And so
it's event-based, right? So,
yes.
but hopefully, yes.
Yes. So I will also publish the final analysis of this important data at this time. Okay.
Sure. Thank you. greatly look forward. Thank you again to our distinguished panelists for an important discussion. Thank you for sharing this important data, advancing the standard of care, showing what the new treatments can do. I'd like to thank again this opportunity to have this discussion and just be share thoughts. I'd like to thank Dr. Ma for his comments as well. And I'd like to thank you, the audience, for your attention as hopefully we're able to share our passion for doing research to be able to improve the lives of patients who have a tough situation as well as their families. With that, I'll draw this discussion to a close.